Welcome to the APLiEM oral board case. So this is designed to just give you an overview of how an oral board case should go. So I'm going to be the examiner and the examinee and reading back and forth. You might also hear some page turning as well. But I'm doing this just to give you guys an approach, at least, on how oral boards should go. So we'll start. The chief complaint, 56-year-old male, is brought in by EMS after a witnessed cardiac arrest. Vital signs on their arrival: blood pressure 95/50, heart rate 65 on the monitor, respiratory rate intubated, bagged at 8 breaths per minute, temperature is 36 degrees Celsius. So I will ask, what does the patient look like? He's a middle-aged male, intubated, pale, and unresponsive to painful stimuli. Okay, I'm going to perform my primary survey. The airway. ET tube is in place at 23 centimeters, otherwise patent. Breathing. No spontaneous breaths. Respirations at 8 breaths per minute by EMS. Okay, circulation. Palpable radial pulse and palpable carotid pulses. Okay, so let's place the patient on the ventilator. Confirm tube placement with end-tidal CO2. Let's place the patient on a cardiac monitor. Can I have the vital signs, please? Yes, blood pressure is 95/50, heart rate 65, respiratory rate now 12 on the ventilator. Temp is 36.7 degrees Celsius. O2 sat 99% on 100% FiO2. Okay, let's grab a finger stick blood glucose. Let's also establish 2 large bore IVs if not already established by EMS. Let's obtain an EKG. Let's also get a chest x-ray for evaluating any lung pathology or tube placement. Let's get some labs. Let's get a CBC, a CMP, coag studies, LFTs. Let's also get a troponin and a blood gas as well as a lactic acid. Can I have some more history about this patient that we know of? Sure. The history of present illness. This is a 56-year-old male presenting after cardiac arrest. According to EMS, the patient was eating dinner with his wife at a restaurant and collapsed on the table. Bystanders promptly initiated CPR. Upon EMS arrival, patient found to be pulseless and in a shockable rhythm on the monitor, with a single shock delivered with return of spontaneous circulation to sinus bradycardia. A single dose of atropine, 0.5 milligrams, was given, and the patient was intubated for airway stabilization with confirmation by continuous end-tidal capnography. He was then transferred to RED in about 15 minutes or so. Great, good history. Do we have any sort of past medical or surgical history? Yes, the wife says that he's had a history of hypertension. He's diabetic. He has a history of coronary artery disease with stents that were placed approximately 10 years ago. He also had his gallbladder out about 15 years ago or so. Great. Do we know any medications that he's on? Yeah, his wife brought the med list with her. It's clopidogrel, simvastatin, and metformin. And it looks like he's allergic to ACE inhibitors. Excellent. Can we take a look at the rhythm strip that was brought in by paramedics? All right, this looks like ventricular tachycardia, and in the setting of no pulses, we would call this pulseless VT. And it sounds like he received 1 defibrillation and got pulses back. Okay, so now I'm going to do my secondary survey. How does he look in general? The patient is intubated, not responsive to painful stimuli. Okay, what about HE and T? He is normocephalic, atraumatic, pupils are equal, reactive to light, no tracking noted, and he's got normal sclera. Okay, what about the neck? Trachea appears midline, no bruits, no JVD. Okay, what about his chest? Bilateral chest rise with rescue breaths, no signs of trauma. Okay, and moving on to lungs. They are clear to auscultation bilaterally, no wheezes, rhonchi, or rales. Okay, and what about his heart as I'm auscultating? Regular rate and rhythm, normal S1, S2 with S3 present, no clicks or rubs. And his abdomen, normal bowel sounds, soft, non-distended. Okay, looking at his extremities, we got full range of motion, no deformities, palpable pulses throughout, no spontaneous movements. Okay, and moving on to his neuro exam. Eyes do not open spontaneously. Pupils react to light bilaterally. Pupillary reflex intact. Does not withdraw from pain, and no posturing. Great. And skin. His skin is cool and pale. Okay, excellent. So, we have an established airway. We're monitoring end tidal CO2. We got our ventilator all set up. We have chest x-ray coming. We got a finger stick blood glucose. We're going to establish central venous axis. I think we should also start or establish an arterial line. We should also get rectal temperature monitoring. We can also administer aspirin. And I think at this point we'll need to consult the CCU or ICU to let them know that we have a patient for him. And we should probably start beginning to chill the patient, ideally to 36 degrees Celsius over about a 2 to 8 hour period. We can start this with chilled saline or cool blankets. He already seems a little bit cool on the cooler side as it is. If we are going to start cooling the patient, then we should also consider shivering inhibition by either paralytic, or we could consider meperidine or buspirone. We should also monitor continuous temp with a bladder probe, or we could do an esophageal probe since he's intubated. We should also probably talk to CCU, but we should probably get him started on heparin, bolus followed by a drip. And then we can also consider GI prophylaxis for his prolonged intubation and prolonged ICU stay here. Okay, now I'd like to review the blood work. Here's your blood work. Okay, I'm not seeing too many abnormalities. Potassium looks good. Coags look good. INR is 1.4. The ABG demonstrates a pH of 7.12, which is slightly acidemic and to be expected in this patient. Troponin looks negative. I'd like to review the ECG. Okay, here is your ECG. So this looks like sinus tachycardia with a possible right bundle branch block. And I'm not seeing any ST segment elevation or significant depressions. Okay, so I think we are stabilizing this patient now. My diagnosis is sounds like he had a pulseless ventricular tachycardic arrest and got pulses back after one defibrillation. We have confirmation of the airway on chest x-ray, and end tidal capnography is at 40 millimeters of mercury. We're monitoring on the cardiac monitor. Let's see. We are doing neurologic exams. We're implementing therapeutic hypothermia, and we're making sure that he's going to be appropriately sedated, and we're taking care of the paralytics for shivering. And so we'll go ahead and give report to the CCU doc regarding this patient. So this is basically how an oral boards should go, and we'll go for our future grand rounds. Of course, you can ask for anything, and as long as you verbalize your thought process and what you're thinking, and you have to verbalize all actions that you want to take. These oral boards are really, really helpful in being able to talk through your process. And they're also helpful to look back on and reflect and see what you can improve on as well. At the end of the oral board, I'll give you some pearls and instructions regarding that particular case that you can take away from. All right, so thanks for listening. Again, this was just a practice oral board read by myself. And we'll give you just kind of a heads up on how we're going to approach this moving forward. All right, thanks.